Hello, my name is Andrew Kaunitz, Professor and Associate Chair in the Department of Obstetrics and Gynecology, University of Florida College of Medicine in Jacksonville. Today I'd like to discuss an approach to prescribing menopausal estrogen more safely. And I'd like particularly to focus on reducing the risk of venous thromboembolism, or VTE, when prescribing menopausal estrogen. VTE, which encompasses both deep venous thrombosis and pulmonary embolism, occurs on an annual incidence of about 2 per 1,000 menopausal patients. We recognize that age as well as obesity and also familial conditions such as factor V Leiden are associated with an increased risk of VTE. We've been aware for decades that pregnancy and use of oral contraceptives, or the pill, increase the risk of VTE, but only more recently with the publications of findings from randomized clinical trials sponsored by the National Institutes of Health, including HERS and WHI, Women's Health Initiative. It's been clear that use of conjugated equine estrogen combined with medroxyprogesterone acetate increases risk of VTE. In fact, from my perspective, the increased risk of VTE associated with use of equine estrogen plus MPA represents perhaps the most important risk associated with menopausal hormone therapy. The question is, can we prescribe estrogen to our menopausal patients more safely in terms of VTE risk? And I believe the answer is yes. Both oral and transdermal estrogen are commonly used to treat menopausal symptoms in French women. And we have findings from a high-quality case-control study from France which support the hypothesis that transdermal estrogen, in contrast to oral equine estrogen, does not increase the risk of VTE. In my practice, I more commonly prescribe transdermal than oral estrogen when treating menopausal vasomotor symptoms. In menopausal women at particular elevated risk of VTE, including overweight and older menopausal patients, including those in their 60s, I'm particularly proactive about encouraging these higher risk women to use transdermal rather than oral estrogen therapy. Hormone therapy continues to represent the most effective treatment available for bothersome vasomotor symptoms and related menopausal symptoms. In addition, hormone therapy is highly effective in preventing osteoporotic fractures in our menopausal patients. Since transdermal estrogen is as effective for these indications as oral estrogen and yet appears to have a substantial safety advantage vis-a-vis risk of venous thromboembolism, I encourage you to, in your practice, as I do in mine, make transdermal as opposed to oral estrogen a first-line approach to treating menopausal vasomotor symptoms and osteoporosis prevention in your practice. Thank you.